Uh, Good evening, everyone. Good evening, Dr. Maha.
Good evening.
Sorry for the delay. Is it just me that I couldn't join, or more? Sorry for that.
Can you hear me all well? I'm wondering.
I can hear you, Doctor. I hope everybody else.
Okay, that's great.
Good evening again to everyone, and my name is Alexandra Jassim, and let me please introduce our speaker tonight. It is my pleasure to welcome Dr. Maha abdulrasoul. Dr. Maha graduated dental sciences from Trinity College in Dublin, Ireland. She is an accredited trainer in safety and risk management and quality improvement. She also obtained her master's degree in quality improvement and patient safety from University of Nottingham. Currently works as quality doctor in quality and safety audit department in quality and accreditation administration in the Ministry of Health. Welcome, Dr. Maha, and the space is yours whenever you are ready.
Okay, good evening, everyone. Unfortunately, I cannot see your faces and I cannot be here in person. And it's really a pleasure to be with you today. This is my second year to present the safety lecture. So hopefully you're going to enjoy it. I'm just going to share my screen now and tell me if you can see it. Can you see that?
Not yet. 1 minute. Yes, it's on. We can see. Thank you.
Okay, that's great. Okay, so today we're going to talk about the principles of patient safety and incident reporting in primary care. It's quite a long lecture. I hope it's going to be an interesting one for you. Feel free to ask any questions in the middle. By the end of this lecture, hopefully you're going to be able to define patient safety and state types of patient safety according to the WHO. Outline the 9 patient safety solutions and relate them to their daily practice. Report patient-related incidents in the correct form provided by the Quality and Accreditation Directorate, and recognize the steps necessary to improve patient safety in the primary healthcare. So it's quite a lot. We're going to start by saying, generally, patient safety is a critical component for providing high-quality care in different areas in healthcare organization. And you need a strong safety culture in order to achieve a successful patient safety system. So what is patient safety? It's basically the absence of preventable harm to a patient during the process of healthcare. Please remember the word preventable. We're going to later on explain what is preventable and unpreventable. So basically what you're doing, we're asking you to please do not do any harm for the patient while he's receiving the care in your healthcare facility. So it's a top priority at every healthcare organization. So when we talk about the patient safety, what we want that the healthcare organization protect their patients from errors, injuries, accidents, and infections. Now, we don't accept less than 100% patient safety, even when we're auditing the hospitals and the primary care. I know that the safety program is new, especially for the primary care, but what we're achieving is 100% patient safety because you cannot go with less, not even 90% or 80%. So what is safety culture? We said we need a strong safety culture to achieve patient safety. So it's a culture where the healthcare professionals are held accountable for unprofessional conduct, but yet not punished for their human mistakes, because at the end, we're all humans. We do mistakes. Errors are identified and mitigated before harm occurs, and this is our major goal, to hold the errors and prevent the harm being reached to the patient. And systems are in place to enable staff to learn from errors, near misses, and prevent recurrence. So we want to create a learning lecture from our mistakes. So what is the current situation in the primary healthcare? Unfortunately, errors and system failures are repeated. They're done on daily basis, and mostly it's because of the system failure. And many events and harms and errors are there, but unfortunately, they're not reported. Why they're not reported? Because there's blame culture. Still, patients, like, the healthcare professionals are being blamed for any incident that happens in the facility. And we don't understand the real causes of these incidents. We always point the finger to the person, and we always look superficially that it's a human error and he should be punished. And the social media didn't help at all with that, because people now they don't understand the principles of patient safety. They don't understand the principles of errors. So what they do, they immediately attack the healthcare professional. So we have so many barriers to achieve the patient safety implementation, but the top 7 are lack of resources. We need resources for patient safety to be there in our healthcare facility. We don't have enough staff. There is work overload. There are many resignations now among the healthcare workers, and this is not helping. We need patient safety technology for certain programs to be achieved fully, and to achieve the patient safety, we need some technology, but it's costly and it's not available. There is a huge resistance to change. People, mostly, we are among of them, that we are accustomed to a certain way of working with things, doing things, dealing with patients. So when a new thing comes along, we can't resist to change. And we will do our best just to not let the program happen, the new thing happen. There is culture of blame, as I said before. There is lack of senior leadership. We need a good leadership, and we're going to talk about leadership in the coming slides and how they can contribute to implementing patient safety. There is poor attitude and behaviors towards safety programs. When we started in 2015, we started by getting the training from the Canadians who came to start the patient safety programs and quality programs here in Kuwait. It was not until 2016 really that we started these programs in the primary healthcare. And it was not that people resisted the patient safety programs, it's just they were poor attitude towards them. They just didn't believe in them. And they acted towards them as if they are they are minor things, they're not important. So it took us a long, long way. Now I can say there's an improvement, a huge improvement for me from the day we started, but still there is a lot of work to be done. Medical errors in general, as I mentioned before, when a medical error happened, it's always related to human failure or error. It's either the doctor is unknowledgeable or doesn't have quite the skills. It shows the errors in the diagnosis, the treatment, and the task execution. And every time there is an incident or any harm done to the patient, it was always that human failures and errors were the cause. It was not until James Reason, he was a British psychologist which worked in aviation. He introduced the systems analysis to errors. This gave us a fundamental insight about the nature of incidents and errors. What he said basically, that safety failures are almost never caused by isolated errors committed by individuals. Instead, most accident results from multiple small errors in environments with serious underlying system flaws. And this analysis came in the late 80s, early 90s. So it was quite late. And still we are in the 2022, and still people believe in the human factor error. So what he created was the Swiss cheese theory of system error. So basically what he said, that any process in the healthcare system is like cheese layers, okay? So the cheese layers act like the defense of the organization system. So if your organization is strong, okay, it will have a whole cheese layer. These gaps that you see them represent the errors, or like, the gaps in the system that can cause the error to happen. So if you can see here, nurse prepares to administer a medication. The error that happened, that patient receives wrong medication and has a respiratory arrest. So if we don't know about this system analysis of the errors, we would say, okay, the nurse committed the error and she was wrong and she should be punished. But if we look at this analysis, we can see there are multiple holes in our cheese. So what are the holes that we have? There is no warning labels on dangerous medications. So she didn't see the labels. There were different medications stored in lookalike bags. So she got confused. Unanticipated increase in patient volume and severity. So she was under stress. There was work overload here and nurse staff shortage. To put these all into consideration, now we can understand why the nurse committed this error and why this error, the red arrow, came across all the defenses of the organizations, because there were gaps. If my organization was strong and these gaps were closed with good and impact patient safety system, the error will be reflected and the error won't go through. So this is basically the Swiss cheese theory of system errors, that it's not the human error that we're looking for, it's the system error. So when we say system process errors, what we're talking about, there are errors in administration. The design of the place sometimes makes you do errors. Like, I'm a dentist. I was an infection control coordinator for a while. I would go to sterilization rooms and I would see the design of the room. It will definitely make the sterilization technician makes lots of error on daily basis. And sometimes you cannot do anything about it because the design of the room won't help you. The organization itself, the policies that they are put, lack of policies sometimes would contribute in errors to be happen. There's lack of training. There are equipments that they have no maintenance, and all of these are considered system and process errors that contribute with the human factor to make the harm reach the patient. So why do we focus on hazard and harm in patient safety? So if we are in medicine, you are all physicians, if we want to reduce the incidences rate of disease, you look at risk factors, you figure out how they contribute to the disease, and then you figure out how to reduce or eliminate these risk factors. It's the same with the safety. We want to reduce harm arising related to patient safety in our organization. So what do? We look for hazards. They are objects or actions with potential to cause any harm. We figure out how they contribute to errors and harms, how they're going to cause harm to my patient, and we go and try to reduce or eliminate these hazards. So effect of these harm arising from patient safety errors, they are enormous. Time is going to be wasted. Financial costs is going to be huge. There's going to be delay in care when we have a patient safety error. The patient is going to suffer some pain. There's emotional or psychological consequence. As you can imagine, an error happened, so the patient is distressed. There are sometimes temporary physical consequences, like a patient fell due to the tiles were not they were slippery. In my organization, the tile is slippery. So it resulted in the patient fall. So he might be okay, just rise and then nothing happened, or he might end up with a hip fracture. So we don't know. Unexpected hospitalization. permanent or very serious damage, and sometimes it will lead to death. And this is all these we want to avoid, not only death. So the WHO, they conducted a safer primary care project in 2005. The goal is to advance the understanding and knowledge about the risks to patients in primary care, the magnitude and nature of the preventable harm due to unsafe practices, and how to achieve safe mechanism to protect primary care patients. So they kind of introduced types of patient safety. There is medication safety, surgical safety, electrical safety, lab safety, infection control, blood safety, equipment safety, and environmental safety. And when you look in the literature, there are many types of patient safety, but this is what we're going to focus on today. So for the electrical safety, from the name, we go and check our portable cords, and if their plug connected equipments are good. We don't overload our extension cords, power bars, and if there is anything damaged, we go and replace them immediately. For the equipment safety, we have to use the equipment right, and it has to be well maintained, operated by trained staff. So many times we have so many equipments, but we don't get any proper training on them. And this may lead to accident and may lead to harm. So what we want to do is to prevent accident and reduce personal and financial costs. Environmental safety, we can look at water supply, the type of water quality that I have. Is it accessible or not accessible in my healthcare facility? Waste management, how I'm getting rid of my waste. Is it in the right way or is it in the wrong way? Like in the dental department, I know we are the waste management of the amalgam, the silver mercury filling, is totally wrong. The cleaning and laundry, it's important. To control the vector-borne diseases and reduce infections in my healthcare facility. The building design. When I design a building or even design a room, I have to consider ventilation. It has to be well ventilated. In some areas, I have to put HEPA ventilations, which are more advanced ventilations. I have to control the temperature. Sometimes when you're working and you're in the clinic and it's too cold, can you achieve the optimum? No. When it's too hot, it affects your achievement. So temperature is very important. Noise, when you are in place and the equipments are generating too much noise, this is going to affect your performance as well. Lab safety, we want to provide the employees in the lab a workplace protected as possible from exposure to human blood and bloody fluids and other biohazards. So in the lab, we ask, it's like the dental, we ask them to put a full PPE with the goggles, mask, gloves, lab coat, and foot protection. We try to protect them from chemical hazards, electrical hazards, biohazards, fire everywhere, the sharp instrument hazards. So basically, we want to identify and control chemical hazards in the lab. We want to monitor and administer hazardous chemical waste disposal program. We respond to chemical spills and accidents, and we want to investigate complaints related to workplace exposures. The infection control, I cannot infection control. With the pandemic, everyone is concerned about the hand hygiene. We need even the needle stick injuries. We want to minimize them in our facility. Surgical safety, what the WHO did was they developed a simple checklist to reduce surgical morbidity and mortality and sentinel events. So the checklist, they deal with three, they divided the surgical procedure into 3 phases. Before the induction of anesthesia, and they called it the sign in, and before the start of the procedure, and they called it the time out, and before the patient leaves the operating room, and they called it the sign out, okay? The time out and the sign out. So this is the surgical safety checklist. Here's the sign in. As you can see, there are checklists that to be filled. then the timeout, all the team, the whole team in the surgery, they have to stop. One member of the team should take the responsibility and will read out loud all these checklists. And everyone has to agree that it has been done. And at the end of the procedure, this is the sign out. The medication safety, you have to remember the 5 rights: the right drug, the right patient, the right dose, the right route, and the right time. Okay. And in addition to that, the WHO also introduced the solutions for patient safety. So in 2007, there were safety solutions 8 memoirs launched by the WHO. They introduced 9 patient safety solutions. There are so many patient safety problems, but they concentrated on only 9 of them. And the reason they chose those 9, because they said they're going to start with these at the beginning. The data that was coming from different countries and different organizations, that these are the top safety problems in the world. And we were proud, like Kuwait was part of this in the WHO when it was launched. And in 2013, the Quality and Accreditation Directorate adopted these solutions as their main patient safety programs elements for hospitals and primary healthcare centers. And this is what we're currently working on. Are you familiar with this booklet? Have you seen it before? Anybody?
I have seen it as a file on a PDF.
Okay, anybody else?
I have never seen this one.
Okay, so this is basically from the Quality and Accreditation Directorate. If your polyclinic is involved in accreditation at any certain time in the past years, this was the booklet they looked for the patient safety. I would be glad to provide it for Dr. Hanan, and she can email it to you, so you will have a look at it. Because what I'm gonna go through the 9 patient safety solutions, but maybe you have more extensive read about it if you want. So these are the 9 patient safety solutions that we're currently working on. So the first one is the look-alike, sound-alike medication names, the LASA medications. It's one of the reasons why the healthcare worker gets confusion about the drugs. It's one of the reasons. Other reasons will be the illegible handwriting, the incomplete knowledge of drug names. I would know the trade name, but I wouldn't know the generic names. There are so many newly available products, so many healthcare providers get confused. So many products now, they have similar packaging and labeling. And with the LASA medication, what we mean by LASA is they are visually similar in physical appearance or packaging, and names of the medication, they have spelling similarities or similar phonetics. So this will cause a lot of confusion. So as you can see here, dopamine, dopatamine, see here similar packaging, similar colors. Here is red, here is white. This is the only difference, okay? So this causes a lot of confusion in the pharmacy and as a healthcare provider. So in order to avoid prescribing or dispensing or the wrong LASA medication, there should be a list of an updated LASA medication in all areas involved, like in the clinic and in the pharmacy. This list should include medication name, the generic brand name written in bolded Tolman lettering. The bold Tolman lettering, if you can see here, hydroxy, the OXY is written all in capital letters. So this is the Tolman, okay? Here, it's Tolman and it's bold. It's kind of with a bold font. So this is what we mean by Tolman and bold, okay? And it's sorted alphabetically. Medication indication. We should know each medication what's indicated for. The LASA medication should not be kept in close proximity in the pharmacy of each other. Okay, so people won't get confused. They should get special labeling, special color codes. And in the hospitals, they worked on that program extensively. Unfortunately, in the primary healthcare, we noticed that it's kind of like, the effort of individuals. If you have a pharmacist that she's really involved in the safety programs, she would go and do that in her pharmacy. But otherwise, until now, it hasn't been implemented fully. As we said before, it should be printed in Tolman, boldface, and contrast background, okay, when prescribed or ordered. Do you get an alert for your LASA medication in the electronic system? Anyone?
No.
So there is no alert or any color-coded something for the LASA medication in the electronic system?
I believe that
there's background color maybe is different.
Okay, go ahead, doctor.
sometimes they apply a color on the drug name, and sometimes there is a pop-up message comes when we write Zyloric, an example. It
Okay.
gives a multiple drug name and just a warning. There is if you have mistake about the name of the drug.
Okay.
All for Zyloric and Zestril. Sometimes they bold the drugs for diabetes with the red color and the drugs for hypertension with the yellow color. Sometimes we see this in the primary healthcare.
And the electronic system, you mean?
Yes.
Okay. So this is kind of a warning. Like it's not like the program hasn't been fully implemented, but this is a good start because before there was nothing. I did a mistake of prescribing Adalat instead of Adol for a patient in the clinic. And I did that, and there was no warning about that these are kind of LASA medications. So it's good that there is something now. Okay, so as we said, shelves and drawers or containers in the pharmacy are labeled, okay, according to the hospital policy or the primary care policy. And again, we emphasize that should be Tolman and boldface because this is what indicates that this is a LASA medication. Okay, so this is what we're talking about. Either highlight, Tolman, or boldface. The second one is patient identification. So how identities get mixed up? We have so many patients, they come with common names or similar names, Ahmed, Muhammad, Hamid. And we have maybe 2 or 3 patients like that. Sometimes in the same days, sometimes on different days. So this is confusing. Staff enters wrong patient information, like in the administration at the desk. When they try to enter the info, they enter the wrong patient identification or the wrong patient information. And patients share or steal identities. And this is a problem. We have 2 sisters that they look alike, wearing a hijab, or they kind of have similar features. So they exchange their ID. So what will this lead to if we have a wrong patient identification? It will lead to wrong drug to wrong patient, inappropriate treatment, wrong procedure on the patient, serious delay in commencing treatment, because if any incident happens, it will cause delay because it will cause chaos. Delay means that the rest of the patients that are waiting are going to be frustrated. So it's a complete chaos. Wrong diagnosis, overexposure to radiation, because this patient didn't need any x-ray. So I prescribed it to the wrong patient, and now he's being exposed to radiation. Wrong patient transported to theater, and sometimes would lead to cancellations of operations. So there is a policy that was in 2018 It should be in all clinics in the primary healthcare. Are you aware of this policy, of the patient identification policy? Have you seen it before?
No, I haven't.
No.
No. No. Okay, this is surprising because it was something that we worked on before COVID in the primary healthcare, and many healthcare, like, I know many medical areas, they distribute this policy, and they did kind of a quality improvement project for it. Okay, so someone has it. Okay, that's good. Okay, so the policy, when you have a policy, this means that you have to adhere to it. Now you are bound to do these things. Okay, that's why we get the policy done. And the policy, it's on all patients, all times. All staff should do it for administrative or clinical procedures when they're dealing with patients or when they're dealing with samples. So this is really important. So this is the policy, sorry. So what it says that the patient full name and civil ID number should be used as the default patient identifiers. In case the patient doesn't memorize any of these identifiers, use at least 2 patient-related identifiers that can be easily memorized by the patient. So when you have a patient coming to your clinic, you should ask him about his name and ask him about his civil ID number. Okay, I cannot remember my civil ID number. Okay, please state your date of birth. I don't think nobody can remember their date of birth, right? So these are the 2 identifiers that they should be asked about. So in the policy, you can see different definitions. Most importantly, the valid civil ID. Always accept an original ID and non-expired civil ID, please. Okay? Don't go for photocopies or for expired civil IDs. With Hawiyati app now, even if the the civil ID is under renewal, the update will be there in the Hawiyati. So you can check on the Hawiyati, okay? When we say patient full name and civil ID number, okay, the full name should be full 3 names, the first name, middle name, and last name, okay? Because sometimes until the 4th name, you will have 2 similar patients, 2 patients with the similar 4 names. So it's really good to have full 3 names. Other acceptable patient identifiers beside the civil ID number, the name, it's a must. If he cannot remember the civil ID, then date of birth, the medical file number if he remembers it, the home address, but this is not reliable because people now they have the civil ID when they were living with their parents and they changed their home address. So this is kind of confusing. Phone number, again, maybe it's not updated. And the patient photo, it should always be checked while you're taking this information from the patient. So how it's done? Okay, it's you ask the patient to give you his civil ID. You actually then ask the patient to give you his name. Don't say, are you Ahmed Mohammed? And the patient will nod. No, this is not acceptable. Ask him, what is your name? And he should state his name. What is your civil ID number? Don't mention the civil ID number for him, okay? So this is how it should be done. And while you're doing this, you check the photo, just for double checking. For patients younger than 5 years old, because they don't have the photo on their civil ID, so this step is missed, okay? If the patient is known by other names, you should always refer to the name in the civil ID. Don't go by the other known names, okay? You should match the identifiers, okay, on the patient ID, on the prescription request, appointment slips, and reports. So you're asking the patient, he's giving you the information. while he's giving you the information, compare it to his civil ID, compare it to the document you have, or compare it to the request you have. So you're cross-matching. If all the IDs or all the documents that you have currently for this patient are all have the same identification. This is very important. Okay. Another thing that is important, that you should educate the patient about the importance of patient ID. When we started this program, patients were frustrated. Are you blind? You cannot see my name? You cannot read? They're always frustrated. So you have to do some kind of like, either when he's coming to your clinic and you're asking him about the patient identification, tell him that this is because for your safety, it won't get mixed up with another patient. It has very huge consequences if this happens. It's your duty to educate the patient about that. So this is regarding patient identification. The third one is communication during patient handover. So we have huge gap in communication during the process of the healthcare service given to the patient. And this can cause serious breakdown in the continuity of care or inappropriate treatment and potential harm to the patient. So when we say handover process in the primary care, we're talking about two things. Either when we're changing shifts, at the end of my shift, a patient came and I didn't quite finish his whole treatment. So I'm leaving, the next physician is coming. So this is going to be a handover. So how this is going to be done? Or patient referral, where I'm going to refer the patient to another facility, or I'm going to refer the patient even to the lab or the X-ray. So the types of communication during patient handover, it's either done documented or verbal. We always prefer the documented, where you have a form and you write all the information that is required from you. The verbal is not recommended, but it's happening. We cannot dismiss that. During our audit to hospitals, we go to the nursing counters and we ask the patient, are you doing, we're asking the nurse, are you doing any verbal orders? No, we're not doing it because it's forbidden. No, it's not safe. But we know that it's happening. We cannot deny that. So there is a way to deal with the verbal orders. If you're gonna do a verbal order, you have to make sure that if you're giving it to your nurse, ask her to please write it down, read it back to you, and get the confirmation that the information given was right. This is very important. Not just only your nurse, even the physician that you're handing over the patient to. So this is really, really important. We're having quite an issue now that the healthcare providers are communicating through WhatsApp. And we don't know whether to consider WhatsApp as a documented or as a verbal, okay? We cannot deny that most healthcare workers are doing that. So it is good that if it's a serious case or if you're handing over a patient through WhatsApp, that you keep the conversation. You don't erase it, okay, as an evidence in the future, okay? So this is really important. So how we're gonna do it documented? We're using something called an ISBAR. So any form that is gonna be handed to you in the future, because I know there is a policy that is gonna be there for you soon regarding the handover. The handover form for transfer and during shifts is gonna be based on the ISBAR. So the I stands for the identification, where you state the patient name, the gender, the civil ID, and the age. The S stands for the situation. What is the chief complaint of the patient? What is the current status? Can you give a possible diagnosis? The B stands for the background. If he has any previous history, any disability. The A stands for the assessment. So did you do any assessment? Did you take any vital signs? Did you record any symptoms? Did you ask for lab tests and they are pending, or did you actually get the lab test results? So you have to mention them. And the recommendation. What do you recommend? What do you suggest should be done next after, like, you're going to hand over the patient or you're going to refer the patient? Then you put your date, the time, and 2 signatures need to be put here for the treating physician and the receiving physician, just to complete the handover process. Okay. The fourth one is the performance of correct procedure at correct body site. So this is mainly when we have a surgical procedure. In the primary care, the dental clinic, they do minor surgery procedures, okay? So we had quite incidents that, so many actually, working on the wrong tooth, pulling out the wrong tooth, okay? And this was not reported. So it is important that you report these incidents when they happen, okay? Because they do happen quite often. In the surgical theater, there is, as we mentioned before, the surgical checklist. And when we are auditing the safety, the surgical safety, we're seeing if the doctors there are filling the surgical list completely. Are they doing the sign in? Are they doing the time out? And they are doing the sign out. Okay. The control of concentrated electrolyte solutions. Well, the concentrated electrolyte solutions, there are medications which have high risk of causing significant harm to the patients when misused, like potassium chloride. So when we're dealing with them, they should be accessed and prescribed and distributed and labeled in a certain way and monitored, and there should be a log and there should be a box where they are placed in. And I saw this in the hospital where they have like kind of a box with the key and there is a label with the high risk drugs. I believe now they removed the potassium in the primary, right? You don't have it anymore?
We don't.
We don't, okay. So this, you can see it in the hospitals mainly, where it's done with other kind of like, drugs that are considered concentrated electrolyte solutions. Okay, moving on, assuring medication accuracy at transition in care. So when we are prescribing the medication or we are dispensing the medication, we want to make sure that it's done in a very safely manner. That's why the WHO suggested that we do something called medication reconciliation. So what we mean by medication reconciliation is a formal process for creating the most complete and accurate list possible of a patient's current medication and comparing the list to those in the patient record or medication orders to come with the best possible medication list, okay? So by doing that, we avoid medication errors such as omissions, duplication, dosing errors, or drug interactions. And it should be done at every transitions of care in which new medications are ordered or existing orders are written. So you have so many patients coming in and they ask for repeat of medication. And meanwhile, they might have gone to another hospital and they had medication from there. And they might take in medication from the on counter, like, from the private pharmacy, and you don't know about. So that's why you have to do the medication reconciliation. So you will know that if you're repeating a medication or you're giving the patient a new medication that doesn't interact with any medication that is taking currently. So what do? You develop a list of current medication. You ask the patient, what are you taking now? Okay. Some patients, they're smart. They bring all their medications with them in the bag. Some of them are super smart. Did you see a chain? Unfortunately, I didn't put the photo. There's a keychain. I saw it on the net where a patient, he just took a photo of all the medication that he has, okay? He laminated them and put them in a keychain, and he has them with them, like, every time he goes to his GP. So this is a very smart way, like, to show the medication that he has. And then you are going to prescribe a medication. So this is another list that you're going to do. You compare the two lists together. You make a clinical decisions based on the comparison. So I'm going to omit this because this drug is going to interact with this one. I'm going to lower this dose because it's not going to work with the new medication I'm giving him. And by doing this, you're developing the best possible medication list. Once you have developed this medication list, you communicate this list with either the patient or the appropriate caregiver in case of you have an elderly patient. So what type of medication that you should put in mind? All prescription medications that they are in the hospital or prescribed from the primary care, the herbals, vitamins, nutritional supplements, over-the-counter drugs, the vaccines, diagnostic anti-contrast agents, radioactive medications, parenteral nutrition, blood derivatives, and intravenous solutions. So basically everything, okay? It's not just the prescribed medication. So when you have a complete medication record list, okay, it should also include, besides of the list of the medication, the patient full name, the civil ID number, the current medication names, medication doses, routes, frequency, and duration, the action taken, reasons for action taken, the physician name and signature, and the pharmacist name and signature. And again, this is something that has been done in the hospitals, and soon the policy for the medication safety and medication reconciliation will be available for the primary care. Okay, so now what you can do, at least encourage your patients to bring their medications with them in a bag. Or if you have the luxury or you have a smart patient, tell him about the chain. This is really smart idea to do, okay? You can discuss with the patient about the risk of the medication, the wrong dose, the interaction with other medications. So by doing that, you're starting your medication reconciliation until, like, the proper form is being provided and the policy is being provided. Okay. Another one is avoiding catheter and tubing misconnections. Again, this is seen in the hospital. So we spread the awareness of the danger of injection wrong medication in the wrong catheter line. And we always emphasize that non-clinical staff should never connect or disconnect devices by themselves, because we have patients that had been long stay in the hospital, and the person who accompanied them think that they know how things are done. So they start misconnecting tubes, and this is really dangerous. Single use of injection devices. So we have been seeing some incorrect practice that has been done in the primary care. Using the same syringe to administer medication, okay, only the needle has been changed, but the syringe is the same. Using a common bag of saline or other IV fluid, and this we used to do it a lot in the dental department, because they will provide us with a big saline bag, and we will just use the same one over and over again. Leaving an IV set in place for dispensing fluid. Accessing the bag with a syringe that has already been used to flush a patient's IV or catheter. And staff not following infection control protocols. That there are protocols, but they're not following them. So why is it important that you change the needle and the syringe at the same time? Just look at this example. So you have a new vial, and you have a clean needle, and you have a clean syringe. Really? You cannot see the slides?
I can see the slides.
Okay. So what happens is I take this syringe, I inject it to a patient, and he turns out to be an hepatitis C patient. Okay. Every time you inject with a syringe, there is a backflow that we don't see. So now we have a syringe that is contaminated. We dispose the needle, we put a new needle, and we go and we withdraw the liquid from the new vial. So what we did now is that we're going to use a contaminated needle, syringe, and we're going to end up with a contaminated vial as well. So all this because we didn't change the syringe as well. So that's why it's very important that we change the needle and the syringe at the same time. The hand hygiene, well, I cannot emphasize this enough. After the pandemic, I think you're sick with the hand hygiene, right? So just remember, with every pandemic or every outbreak that we had, the Ebola, the H1N1, the coronavirus, the first line of defense was always the hand hygiene. And it's very important that you know the correct way of washing your hands. It should be done 40 to 60 seconds, not less than that. And if you're going to perform a hand rub, there is also a certain way on how to do it. It's just not applying the liquid and rubbing your hands and that's it. Okay. So it is important and should be done to 20 to 30 seconds at least. Okay. So who is responsible to implement the 9 safety solutions, the types of patient safety that we talked about? Everyone. Everyone in the healthcare facility, including the patient. Okay. So any questions? This is part 1 done. Are you all good?
I guess no question, Doctor.
Oh, okay.
Continue.
Okay. So you want us to continue? No break, right?
I think so.
Yeah.
I think so. Let's continue.
Okay. Okay, that's great. Okay. So we're going to move now to the incident reporting. So the purpose for incident reporting, again, to document all safety-related incidents in healthcare setting. We talk about the mistakes, we discuss the mistakes, but we don't document them. So that's why we're influencing the incident reporting method. And we want to analyze the real reasons behind the incident occurrence. We just want to omit the blaming culture and concentrating on the human errors. And we cannot do that unless we have a documented incidents with proper analysis for them. So what is a patient safety incident? It's any event or circumstances which could have resulted or did result in unnecessary harm to a patient. Okay, so even if it didn't result in a harm, this is a patient safety incident. And remember, only when the patient is in your healthcare facility that I consider it a patient safety incident, or you provided the service for the patient, and after a while there was harm reached the patient. Okay, so if before he came to you in the parking lot, he collapsed or something, this is not a patient safety incident. Okay, it's just while receiving the service or while he's in your healthcare facility. There are some important definitions that we should know in order to complete or to know how to report an incident. We should know about the unsafe conditions, the near misses, the no harm events, the adverse events, and the sentinel events. So the unsafe conditions is an object or activity which has the potential to cause failure, damage, injury, or harm. It's different. So what's the difference? Now we have a truck here, okay? And you can see here, there are some boxes hanging there. So there is a risk that these boxes might fall, okay? But when they fall, there's nobody here, okay? So this is kind of an unsafe condition or a hazard. Like there is a risk that something wrong is gonna happen. The unsafe act, when I go and I stand underneath these boxes. So now the chances of these boxes to come out and hurt me, they are more a lot, okay? So this is what we mean by unsafe act and unsafe condition. We have unsafe conditions in our primary care when we have broken chairs with sharp edges, and maybe a child will come and will play with these sharp edges and harm himself, okay? We have unsafe acts when we write an eligible prescription or a transfer sheet. So we're doing something that might cause harm to the patient, because who can read this? Okay, we're placing LASA medication without any labeling, without any color coding. So this is disaster to happen. Okay, so the unsafe act, the unsafe condition, they may all lead to accidents. The near miss, it's an incident that could have harmed the patient, but it didn't reach him. Like, I prescribed the wrong medication, and then I realized, so I called the pharmacy and asked him, well, the patient, when he reached you, please don't dispense this medication for him. I was wrong. Send him back to me. So the doctor here got aware that he prescribed the wrong medication, and he corrected the mistake, and no harm was done. But does that mean that I cannot report it? No, I should report that. Why? Because if I don't report it and it goes like unnoticed or unmentioned, what happens is it can happen again. It's maybe not because I was unaware of the medication. It's because maybe it was a LASA medication and it didn't give me the alert, or it didn't give me the alarm. That's why I asked you, do you have any alarm or any indication that this is LASA medication? So if this happens, this means that it's not my fault alone, it's the system's fault. And we have to work on the system. We should put alarms. That's why near misses should always be reported. But unfortunately, they're not being focused on, or they're not being recorded because no patient harm done. And sometimes the healthcare provider, they don't feel any guilt about it. Okay, so what? Nothing wrong happened. So let's go on. The no harm event, it's a serious error that reached the patient. Okay, so we have now an error that happened, or a mistake that has been done, and it reached the patient, okay? But it didn't harm him for two reasons. Either it's his chance or it's medication. What do you mean by that? So the patient received a contradicted drug, but didn't experience any adverse drug reaction. Why? He's lucky, Allah sitar, I don't know. Okay, it just, nothing happened. But not everyone is fortunate enough, okay? So he might took in the drug, okay, but I acted quickly towards it, okay? So I gave him an antidote for it. So I mitigated the harm. So this means that the error has been done, but no harm reached the patient. The adverse event, it means no. Error has been done, incident has been committed, and it reached, and it did harm the patient. Okay, so this is what we mean by adverse event, harmful incidents. The adverse events, they can be preventable events and non-preventable events. The preventable events can be like medical errors. The medical errors themselves can be divided into two: the error of commission and the error of omission. Okay, the error of commission is doing something wrong that leads to undesirable outcome, like you're misusing a drug or misusing the process itself, or you're overusing it, okay? For example, you're ordering a medication for a patient with a documented allergy to that medication. So you're misusing the drug. So this is error of commission. The error of omission is failing to do the right thing. And this also leads to undesirable outcome, like you fail to prescribe a VTE prophylaxis for patient after hip replacement surgery. Both of them are adverse events and they could have been prevented, right? Because it was done, and if I knew enough, or maybe because of a system error, this could have been prevented. But sometimes adverse events happen, and I usually followed the right procedure. I did everything right, but again, the adverse event happened. So these are non-preventable adverse events. Okay, so unexpected harm arising from a justified action where the correct process was followed, like an unexpected allergic reaction in patient taking a medication for the first time. So usually we report the preventable adverse events, and sometimes people report the non-preventable adverse events, and during analysis we know that it was not the fault of the healthcare provider. The sentinel events, they are types of adverse events because harm has been done to the patient, and they are defined as unexpected occurrence involving serious physical or psychological injury, like loss of function or limb, or death. When we introduce the sentinel events in the safety programs, they always related the sentinel event only with death. No, as you can see later on, it involves many other things beside death. So in Kuwait, the incident reporting system is voluntary and confidential for all the incidents. So any incidents that you have, if it was an adverse event, if it was a near miss, it's up to you. We recommend that you report, we encourage you to report, but it's not mandated. But in the sentinel event, you are mandated to report the incident. Okay, so that's the difference. When you have a sentinel event, la samahullah, you have to report it. So this is the list of all the sentinel events. It's usually attached with the incident report form. It should be there when you are completing the form. You should have the sentinel event list beside it. So have you seen this before? The sentinel event list?
No.
No?
No.
Okay. Have you reported or used the incident reporting form before?
I used the incident before in the Farmania hospital for undesirable injection. Yani, accidentally I do injection by mistake for I harm myself.
Okay, okay.
When I do stitches, unfortunately by mistake I hurt my hand by the pin. Then I do instant report. Then I do the vaccination. That's what يعني maybe 2 months ago.
So you had a needle stick injury.
Yes.
Oh, okay. The needle stick injury, it has a different form.
Yeah, it is.
Yeah, it is. But what we're talking about is an incident reporting form. So you haven't actually reported any incidents before, like
No.
errors that has been like, encountered during your...
No.
Okay. Anybody who has reported an incident before or familiar with the list? Okay, so I guess you're all new to that. Okay, so this is the list, okay, that has all the incidents that considered sentinel. Okay, so it's not only death that we considered sentinel. So, like, for example, surgical or other, can I see if I didn't zoom that. Okay, so surgical or other invasive procedure performed on the wrong body site. So the example I gave before, if I removed or I performed a procedure on the wrong tooth, this is called sentinel event. I'm mandated to report this incident. Okay. Surgical or other invasive procedure performed on the wrong patient. So this is again a mandated to report. Unintended retention of a foreign object in a patient after surgery or other invasive procedure. Again, in the dental, during the root canal treatment, we use special files to remove the nerve from the tooth. And what happens is sometimes the nail, the file is very thin and it gets broken very quickly. So it stays in the tooth. We had so many incidents that a patient comes after a while and he's experiencing enormous pain. And when we take an X-ray, we see this file in the tooth. The previous doctor or dentist who broke that file didn't report that incident and didn't mention it in the medical, in the medical file of the patient. So this is a sentinel event and it should be reported. Anything related to the product or the devices, like patient death or serious injury associated with the use of contaminated devices provided by the healthcare setting. This is called sentinel. Patient death or serious injury associated with intravascular air embolism. Okay, this is called sentinel. For patient protection events, if you discharge or release patient who is unable to make decision to other than authorized person, this is sentinel event. Elopement of an incompetent patient and resident of any age, this is sentinel event as well. Attempt suicide, self-harming results in serious injury. The patient is harming himself in front of you. This is sentinel event. Patient death or serious injury associated with a medication error, wrong drug, wrong dose, wrong patient, wrong time. This is all sentinel events. Radiological events, again, the potential criminal events. Did you have any drama in your clinic? I had many with the dental patients. Like we have an assault. I experienced an assault from a patient. I was cornered in one side of the clinic. If you have a case of abduction, did you remember where in Amiri Hospital where someone impersonated himself as a doctor? Do you remember that incident?
I believe, yes, I heard this one from
Yes.
media.
Yeah, this is a sentinel event, and it took because of the social media, it was really like a big deal. Okay, and people started talking about it. There was another incident that took a quite toll, but this was because death was involved. Did you hear about the child who, after the dental anesthesia, died? Did you hear about that incident?
Yes, doctor, I would like to hear
Yes, we did.
the story.
We
Yes.
did.
Oh, do you want to hear the story? Well, it's like the patient came with his mother to the dentist to have a regular, treatment. And the mother didn't tell the doctor that he was diabetic. And I think he was uncontrolled diabetes. And he didn't have any breakfast on that day. And because the mother wanted the treatment to be done, so all this information was not given to the dentist. And he gave the anesthesia and the patient went in shock. According to the CCTV cameras that they were there, we don't have an emergency cart in the dental department. And the dental department is in the upper, always on the upper level of any primary care. So what the doctor did is he removed the patient from the dental chair, ran downstairs to the emergency room, and then from there, it was the responsibility of the emergency team in the polyclinic. And unfortunately, the patient died. Immediately, it was the fault of the dentist. And as you can remember, the social media was buzzed with how incompetent the dentist was, how it was his fault, how could he not have any training, why he couldn't resuscitate the patient, and all these things, and it was huge. And unfortunately, the doctor, the dentist, was immediately removed from his work, and the whole, I think the whole thing took 2 years. It was a couple of months ago that he was cleared from all the charges after intensive analysis and investigation. And unfortunately, nobody mentioned that he was cleared of these charges. The buzz that happened, the incident when it happened, the buzz that happened in the social media, blaming and pointing fingers to the dentist, when all the investigation happened, nothing was mentioned. In your opinion, do you think that it was a human error, a system error? What do you think?
I believe it is a system error because diabetes has nothing to do with anaphylaxis. It is just a percentage of people have anaphylaxis due to lidocaine anesthesia. So,
Okay.
so there should be a paper being written before the procedure has to be done, that the mother should be informed that this lidocaine can cause anaphylaxis, etc., etc., etc. She has to sign to sign a paper that she knows that this might happen. The child could have this thing. So it's not a doctor error. That I think we need not a patient and safety and the quality. We need a doctor safety and the quality procedure.
I know it's so many things lacking. If you can follow my story, it's like, there was no consent. The mother didn't give the full information. We didn't have any emergency card in the dental department. I cannot remember the time I got a training for an actual training for emergency cases happening in the dental department. And we deal with lots of equipments, we deal with a lot of patients with background medical diseases, we give anesthesia, so it's quite dangerous. And this just tells you how, the blame culture that we have, unfortunately, in our society.
That's why
Okay.
we need to let the patient sign a consent paper so that this injection could do 1, 2, 3, 4. Like we have in our primary, the most dangerous injection is Olfen. Olfen could cause a sudden death. The patient should be informed. He has to sign a consent if he demands the injection
Yeah.
to relieve his pain.
Yeah, but the problem is the doctor didn't know that he was diabetic because the mother didn't tell him. We have this problem with the patients not telling us that they are diabetics or they have blood pressure because, they're going to be a delay of treatment because we're going to ask them to check their blood sugar. We're going to ask them to check. So he's going to go back and forth. So this is delay of treatment. We have so many patients that are not telling us they're the right medical history because they don't want any delay in their treatment. So here is some incidents that happen in real life and how it's dealt with. And I was really ashamed from the ministry and the team that held the investigation, because there were no press conference, no any official reporting from them, any documents coming saying how the process of the investigation is going on. So this might have cleared a lot of things for the public, but hopefully one day we're going to reach that, hopefully. Okay, so as we said before, the sentinel is not about death. We have so many incidents that could be considered sentinel. Okay, so in the policy, if you cannot remember all the definitions that I gave you, they are there in the policy, okay? And they are there in the form itself, at the top of the form, okay? So then you will know what you are dealing with. So what are the barriers for incident reporting? First one is fear of blame. high workload, I don't have the time to report. Lack of feedback. We have so many people, like, I was working in Hawali, and we have people, they were interested in, like, incident reporting, and they started reporting, but unfortunately, they didn't get any feedback after reporting these incidents. So what happened? What changes are you going to do after this incident? So it put them down. And there is a belief that the incident didn't warrant report. As I told you, with the near misses, nothing happened, no harm done. Why should I report it? Nobody knew about it. Okay. So some solutions to overcome these barriers is reassurance to staff about reporting processes. And this is the part, like, the essential part of the committee of the safety and quality in the primary care, to keep on spreading the word about the importance of reporting of incidents. We should have simplified methods of reporting. You're gonna see the form now, and it's so complicated. It has things that related to hospital and primary, which makes you go, like, round and round to find the thing that is related to you. So it should be more simplified. You should always have clear definitions. The definitions I gave you, it should be clear to all healthcare professionals who are going to report the incidents. So you have to give education, and feedback is so important, so that people don't get frustrated. So actually, the incident reporting is part of an incident management process. Okay, so we're not just reporting the incident and that's it. We're identifying the incident, we're reporting it, we're prioritizing it. Then there is a team that's going to analyze these incidents. They're going to develop recommendations and action plans. Then they're going to implement them and see if are they working their action plan or not. The recommendation they put, is it working? Is it not working? And then they give the feedback. So it's a whole process that we are dealing with. So the identification of incidents, as we mentioned before, we cannot stress it enough, you should identify the incident and you should report it. If you know the definitions that I gave you, if you go and read about them, you will know what to report as a patient safety incidents, okay? And you always should report all incidents, whether or not it led to patient harm. So the reporting itself, again, unfortunately, it's only patient-related incident. It's not staff-related incident. So as one of you mentioned before that had a needle stick injury, this is another kind of form that you are filling, okay? It's applied to all healthcare providers. It's applied to all care levels, primary, secondary, and tertiary. It should not be used as punitive or punishment tool at all, okay? So whenever a person had an incident and he reported, it shouldn't be used against him, okay? And both patient and staff confidentiality must be protected. Like, I know a patient who committed an incident, I don't go around and gossip about it and, like, expose him all around. We're all humans, we all do mistakes. He had the courage to actually report it. So, okay, he's a better person than me because he actually decided to report it. So there is a ministerial decree about it. And there is also a policy. I hope that you have seen this policy before. It should be in all polyclinics, okay? And it mentions here that it should be completed. All incidents should be by the person who committed, witnessed, or is familiar with the incident. It's always preferred that the person who committed the incident, he's the one who write the incident form. Okay, he decided not to write the incident, but I was there with him. I can write the incident form. But if I heard about it, I'm not eligible to write the form. I'm not eligible to write this incident, okay? Then the head of PHC should regularly audit incident reporting forms. So if you don't have any incident reporting forms available to you, you should ask either the head of PHC or the head of nursing. These are the people who should provide it to you. All clinics should have safety and risk management committee, okay? And the head of this committee should make sure that the incident reporting boxes are allocated, and all healthcare workers know where are the boxes. So when they complete an incident form, they know where to put the box, okay? They should ensure the confidentiality of the patient and the staff. Should not be placed in the patient's medical record. We had an incident done by a nurse, and I was surprised that the head of the nursing department in the medical area, she had the original incident form, and this is wrong because this is confidential. It's in the polyclinic, and if the quality and accreditation directorate orders it, it goes there only. It's not used at all. If they want to refer to the incident, a report should be written about the incident, but the incident report form should not be used at all, and it should not be attached to the medical record of the patient. And no copies of the incident form should be done, okay? Even for analyzing. If you are part of the committee and you want to analyze the incident, you have to have the original form, not a copy from it. Okay? So it's the responsibility of all healthcare workers to identify and report all incidents, adhere to the requirement of the policy, and whenever they are, you are asked to cooperate in the investigation, you should be part of the investigation. Okay? So this is the form. Are you familiar with it? Have you seen it before? Filled it before?
Yes.
No, for me, no.
No? Anybody else? Okay, so it's quite a complicated form. Okay? Yeah? You familiar with it?
Yes, yes, I'm familiar and I filled it before, but now in my center we fill up online form as a I think it's a
Electronic
Google
form. That is
yeah.
good. Yeah, that is good. That is much easier, right, to fill?
Yeah, I mean the steps are probably similar, but easy to do it. You
Yeah.
don't have to look for the paper and.
That's really good. Yeah, that's the next step, and I'm glad that some people are doing it actually. Okay, so this is the form. The most important page is this one, the last page. Okay, because it will give me a narrative of all the things that is going to happen. Okay, so describe the incident, what, where, when, and how it happened. Okay, so basically you're going to write me the story. This is what you're going to do. And it has to be in full, complete narrative description with timing or sequence events. And you have to avoid using words like I had a poor staff, an inadequate nurse, or careless nurse, or something like that. Okay, so this is not quite acceptable. So you have to write me the story because I wasn't there. I need to know what happened. So you need to put it in your good narrative state. Then you should mention if the patient has been evaluated. So if he's evaluated, yes. If he was not evaluated, no, not applicable, or you don't know if he has been evaluated or not. And if he has been evaluated, what have you done? Okay. So did you take any follow-up observation, diagnostic studies, had any results or related treatment for the patient? Okay. And only clinically relevant and factual information should be included in the record. Okay. If the patient sustained injury, fractured, there should be no exaggeration of what happened. Just the facts. Mention the facts. Okay. Describe the immediate actions or treatment, both clinical and non-clinical, taken by the staff to stop or decrease harm. Like if you had an incident where the ceiling of the waiting room just partially fell, okay? So what did you do? Did you evacuated the the people from the room? Did you take everybody out and then close the room? Did you call any supervisor? What did you do? Okay, so this is what you should mention there. Okay, did you provide any immediate care? Did you prevent the immediate recurrence of this incident? Did you notify the director? Remove any malfunctioning equipment? Sometimes you have an equipment that starts smoking, so switching it off is kind of like one of the actions that should be mentioned that you have done to prevent the harm being spread or being more. Gathering and securing evidence. So this is when you have a patient hit a healthcare professional, like I would see with a staple, for example, okay? So you decided to keep that staple as an evidence. So this is an action that you have done, okay? And this will help in the investigation. And you notify the police and the security. So all these actions should be mentioned in this box. Now then, indicate the reasons and contributing factors that caused or contributed to the event. This is very important because the person who actually was involved in the incident in his department, he's the most knowledgeable person. So you would know what led to this incident to happen. I can come and list few things, but because you're there working in your department, in your clinic, on daily basis, you know what could have contributed. Is it the work overload? Is it because we have shortage of staff? Is it because the design of the clinic was not helpful? So all these contributing factors, in your opinion, that might cause the incident should be placed in that box. Write as much as you can, okay? What will happen is the committee will look at these contributing factors and they will say, okay, yeah, this is valid. This is not valid, okay? So they will take this into consideration, okay? And it will help them to find the main reason for the error that happened. Then you should recommend some corrective actions. So, okay, you thought the shortage of staff was the main reason for this incident to happen. So in my recommendation box, I will put, we need more staff. We need more nurses, okay? Don't underestimate your writings or your recommendations. We had so many situations that we looked at incident reports for analysis and we couldn't come up with recommendations better than the one were provided by the person who committed the incident. So it is really vital that you write your recommendations, okay? Then we will go to the form. Do you want me to go through each part of the form or are you familiar with it enough? Because I was asked to go through the form with you.
Can I ask one thing?
Sure.
I am reporting an incident, not a doctor or a nurse or a colleague, right? I'm just reporting an incident.
Yeah, as it happened.
And this form is delivered to who?
This will go to the committee, the safety and quality committee in your polyclinic. They will gather all these incidents, okay? And then they will prioritize them to see which incident they will act upon first. If the incident was serious, it was repetitive, it happens a lot of times, okay? Then they should look at it and they will say, okay, we will take this incident and see how we're gonna fix it or prevent it from happening again. And this is the work of the safety committee in your polyclinic, in association with the safety department and the quality and accreditation directorate. They work together. Then after recommendations and the full analysis, and if there's something that can be done to prevent this incident from happening again, recommendations will come, actions will be taken, and it will be provided to the department or to the person that has reported the incident. This is the ideal situation of the incident process. Okay? You don't know where your incidents are going after you're completing them?
Yes, you just told me, but we don't have this system in my clinic.
Okay, so this is what should happen, because otherwise maybe your head of department will take this incident and work upon it. But when you have a committee of, like, a safety committee, the advantage is that you have the head of the department, a representative from the department, you have the head of the polyclinic, you have representative from other departments as well, because some incidents are related to many departments, not only your department. Like the clinic and the pharmacy, when a medical error, a medication error happens, like, in prescribing or in dispensing, so they look at the clinic and they look at the pharmacy. So it's good that you have a committee there in your polyclinic that will work on such incidents. Okay, so I will go quickly, okay, in this. So at the end, it's advisable that you write your name. So during the investigation, we will know where to go back to. But if you don't want to, you're not obliged, okay? Okay, so this is the policy. Everything we mentioned is there in the policy. You can go back to the policy and it will tell you step by step what to do. So this is your form now, okay? So you write the name of organization, you are in primary, you put the date, the time of the event, and the location where it happened, okay? Now you put the type of the event, the sentinel, adverse, no harm, near miss, or unsafe condition. Then you put your patient information. You fill this. This is quite helpful sometimes. What was the mental capacity of the patient when the incident happened? Was he alert, confused, sedated, unconscious, or was he mentally incompetent? Okay. The stage of service, you always put outpatient because we don't have inpatient. And in which stage did it happen? Is it in the emergency care, the pre-visit, during consultation, post-consultation, in the referral itself, the transport of the patient, or in the follow-up? So these are all the stages that incidents might have happened. Then we have all the form divided according to the nature of the event. We have 9 sections: the administration-related incidents, the medical record-related incidents, the clinical and surgical procedure-related incidents, the decubitus ulcer, the investigation-related incidents, product, device, patient protection, and environmental-related incidents. So for the administration, it's anything has to do with appointments errors, patient flow through the healthcare system. So, now with the non-Kuwaiti patients, when they have to pay for the some of the services they have to pay for. So they pay in the beginning, then say if they go for the dental department, we want to take x-ray, they go back and they pay, then they go back to the clinic, then they have to pay for the service, they go back. Going back and forth, this will affect the flow of the service of the patient. So this is something that you can cause some incidents, okay? Information technology related events, anything related to the IT, and anything related to the management incidents. Policies are not there, the management handled the situation very badly, okay? The medical records, anything has to do with the file of the patient, okay? So document missing or unavailable, unclear, ambiguous, or illegible documentation, wrong information documented, delay in accessing the document, incomplete information document, and wrong patient document, or any other thing that is not specified here. For the clinical and surgical related incidents, there is the stage of care, in which stage did it happen, and then all these things that might happen. For example, you treated the wrong patient. Consent related events. like for, I keep on giving examples for the dental department, but you can give me examples as well. Like we are removing third molars, which is it should be done after writing a consent, but we don't have a consent. So we're doing it like this. So this is an incident because sometimes the tooth is placed in such a way that even the most skilled dentist will cause injury to the nerve, and the patient will end up with numbness that will last for 6 months. So this is an incident, and it might happen without any fault from the patient skills. So a consent should be there, but it's not there. So this is an incident, okay? Patient fall, improper performance or technique of a procedure, okay? The decubitus ulcer is mainly with the home visits, and you can see them in the hospitals with the patients that are in the wards. You need to know the stages of the decubitus ulcer, because when you are reporting, then there is a question. Patient had decubitus ulcer risk assessment on admission, yes or no? So you need to know the stage, because patient admitted with decubitus ulcer was maybe grade 1, then changed to grade 2, or was grade 2, then changed to grade 1. Might have improved, okay? Or patient developed ulcer in hospital. Okay, it went from grade 1 to grade 2. So you need to know your stages. Okay, the investigation-related incidents, they had to do with the lab, the diagnostic imaging, okay? So we have in the ordering, the investigation, we have in implementing the investigation, we have in reporting the results, and we have in the clinician responding to the results. Sometimes incidents happen when the doctor has received the blood results from the lab, but the way he communicates them with the patient is wrong. Okay, so failure to respond to test results, failure to respond to test results timely. Every time you see the word timely, it means that you acted late. Okay, so where did it go? Stopped presenting. Okay. Okay, so I lost the screen. Can you see the screen?
Yes, we can see your screen now.
Yes.
Okay, because I cannot see it myself. So I don't know where I am.
We see the screen, but on top of the screen, we also see Teams group itself. So maybe you have to minimize the Teams program. I'm not sure.
Okay. I don't know what happened actually. Okay. I cannot see the screen.
We see the screen of your laptop, but not the slides.
But not the slides, huh?
No,
oh yeah, the slide disappeared. Program. I don't know why. Okay, so I stopped sharing. I want to share the content again. Okay, so I will go again and see. Okay, here we are.
Yeah, we can see the slides now, but from the beginning. Mm-hmm.
Okay, so I need to go. I don't know how to go faster. I think it was on. Sorry about that. Okay.
No worries, doctor. Maybe doctor should
Sorry.
prepare questions. If anybody has questions for the end, think about them now.
We're almost there. Okay, so we were here. Can you see that now?
Yes, investigation related
Yes.
incidents.
Okay, that's good. Okay. So then we have the product related incidents. Okay. And there is, sorry, it's anything that has to do with medication, gases, blood components, or biological products. And by the biological products, we mentioned the vaccines. Okay. The incident can happen the supply and ordering, storing, prescribing, transcribing, preparing, packaging, dispensing, administration, monitoring, or any other thing that is not mentioning. Do you know what transcribing is?
What again, please? What?
Transcribing.
No.
Okay, so transcribing is when you write, like, you have a medication and you write it from one document to another. So you get sometimes, you get the spelling wrong, or you get the dose wrong, or you get the numbers wrong. So this is errors in transcribing. It's just like, the information that you transfer from one document to another is wrong. Okay, so we will have an incident in wrong patient, wrong dose. It can be a contaminated product, or it's a product not ordered. There's wrong storage, wrong time given, wrong frequency. Okay, the medication or the vaccine gave an adverse reaction. Okay, so all these are considered in the incidents. The device-related incident, it has to do with the equipment. So you write the device name here, the serial number, okay? And then anything that has to do with the equipment. Its equipment is not available, the setting of the equipment is wrong, the equipment has malfunctioned, equipment has incorrect reading, inappropriate for the task. These are all considered incidents. In the patient protection and behavior criminal, this is, we have categories here. So did the patient put the harm on himself? So it was self-inflicted, or staff member caused it, or he did it to another patient, or the visitor, okay? So you just tick whatever happened. We have care provided by unlicensed provider, and we mentioned that incident that happened before. Abduction, elopement, suicide, sexual assault, risky, reckless behavior. This is where you put if you had a patient attacked you physically. Okay, so whenever, and God forbid, of course, if you had a patient that attacked you physically, there where it goes. Okay, attempted suicide, breach of confidentiality, and this actually happened once, but it was not reported. It happened to me. I was the patient, and I was with a doctor, and I was talking about a sensitive issue with the doctor, and a colleague came, and he was just there, and the doctor asked me to continue with my sensitive stuff, so I didn't like it. And I actually reported to, I was the patient at the time, but just be careful, some patients, they consider this as a confidentiality. Some things that they tell you, they don't want other people to hear it, even if it was a colleague, especially if he was not consulted on that matter. So you just have to be careful about that incident. Environmental related incident, if you the patient experienced electric shock, infectious disease exposure, burn from any source. This happens a lot in the dental department as well, because sometimes dentists used to use instruments that are just has been out from the autoclave and they are extremely hot, and they will use it on the patient's mouth, and the patient will suffer a burn. So this should be actually reported. Okay, facility related incidents, hotel service incidents. So all these items in the form, you can put them in your as incidents. Okay, if anything that is not mentioned, there are boxes that says others, and then you can put them there. Okay, the form after completion should be placed in a specified allocated boxes and collected by the assigned member of the Safety and Risk Management Committee for the analysis. Okay, so just a quick exercise for you to see if you grabbed it. The doctor by mistake prescribed Ziloric instead of Zyrtec. So where would you put it in your form? Do you have actually forms with you? I asked Dr. Hanan that you bring forms with you. So anybody will go ahead to see where he can report this in the form, under which section?
I don't have my my form prepared. Nobody told me to prepare it.
I'm so sorry about that. I asked Dr. Hanan. Okay, so any ideas? Where should this go? Ziloric instead of Zyrtec?
مساء الخير يا دكتورة. I have one of incident report form.
Okay.
يعني a type of product medications.
Yes.
Yeah, and that in that box. Yeah, in that page, we will put it in medication form. This one. Yeah.
Yeah, so a type of product, medication, right? And the product related, under the product related, then you can put it under medication, and then the stage, which stage you will choose. I have it on screen if you don't have the form with you. So was it during supply and order, storing, prescribing, transcribing?
Prescribing.
Prescribing, right? And the type of incident? It's in the same box.
Yeah.
It goes under which, anybody else? Can you see the screen?
Yeah, I'm with you on the screen.
Okay, it can go under
wrong product.
Wrong product, right?
Yeah,
that's right. So it's medication prescribing under wrong product. Okay, that's good. Okay. So the other example, doctor gave patient a wrong appointment to chronic disease clinic at time when clinic is closed. So the patient came and he was frustrated that the doctor gave him a clinic and the clinic is closed. Where do you think? Okay, I will, because since you don't have it, it can go in administration, in the appointment errors. Okay, it can go there, or it can go in the clinical related incidents during intervention, okay, and unavailable care. But it will fit mostly in the administration related incidents. Are you with me? Does it make sense? Does it make sense?
Yeah, administration related incident.
Yeah. Okay. Yeah. So this is quickly, just going through the form, just giving you quick 2 examples. Just to remember again and again and again, the reporting should be for learning, not for blaming. Okay? And this is what our leaders should know. So we will promote the incident reporting more often. Okay? So any questions before we go for our last bit, the last 10 minutes in our lecture? Okay. Okay. So we'll move on. Okay. On the last part, what can we do to improve the patient safety generally, or the safety programs in our polyclinic, in our primary healthcare sector? Okay. So there are many things that we can do, but if we manage to do some of them, we might have a good patient safety culture or patient safety program in our primary healthcare. So the first one is to build a positive safety culture. Okay. So what we mean by a positive safety culture, that we have healthcare organizations that are open, informed, just, where reporting and learning from the errors are the norms. So we are dreaming. This is our goal. Okay. This is where we want to be. Okay. So what we mean by open, that when we go and discuss the incidents, we discuss the errors, I feel comfortable to discuss them. I'm not afraid. I feel that the safety errors is something that happens, and we all understand that it's not always the human error, it's system errors as well, and we can talk freely about them. Informed culture, the leaders will understand that there are organizational and there are environmental and there are technical factors that can contribute for the incident to happen or for the error to happen, not only the human factor. Okay, so they are informed. They know exactly how to analyze and investigate an incident. We have a culture that value reporting. Okay, so they are committed to report any incident that happens, and they go and investigate it and analyze it and will take all the measures to see that it will not happen again. And from these mistakes and errors, we take them as opportunities for learning. We learn from the mistakes. We don't punish from these on these mistakes, what we learn from these mistakes. And we have a just culture. So, as we said, the person should be accountable if he did an error. If after my investigation, it showed up that, okay, it's a human factor and the healthcare worker lacked, like, the skills, or he lacked the knowledge, that's why the incident happened. So I hold him accountable for that, but at the same time, I don't punish him. I go and I train him. I go and I will do other things that will increase his skills and will develop his knowledge. Okay, so I have to be in the middle, not punitive and not blame-free. This is what we call a just culture. We should have a leader and leading, like, leading leadership that support the staff. So these models, these are leadership models, okay? We have the Blake and Mountain managerial grid, and we have the path and goal model. What basically our leaders are now, okay, they concentrate on the, the production of the tasks, but they don't concentrate on the people. They don't care about their people. They don't care about the followers in the leadership, as they say. All they care about is the job to get done. They don't communicate with the people. They don't communicate with the followers. So they are, oh, again, it happened. I don't know what happens. Any ideas what happened?
No, I have no idea. But yeah.
It's frustrating. Okay.
Mm.
Okay. So, oh God, again. So I think I will go. Okay, this is quicker. Sorry about that. I've always been very bad with my IT skills. I have to work on that. Okay, so where are we?
Don't worry,
Yeah.
doing great.
Okay, so here we are. Okay, so we're currently here. The authority compliance management. Okay, they have directive style. They want things to be done, and they should be here in the middle of the road management or the team management, where they want things to be done. At the same time, they have high concern about the people. So this is where we want our leadership to be, okay? Even in this model, they are directive. They tell you 1, 2, 3, do this, do that, okay? And they want achievements to be done, but they are not supportive. They should be supportive and they should participate themselves. So that's why the ideal leadership is to have an adaptive leadership style, where when we have a technical or an adaptive challenge, like I introduce something new to you, okay? So what this leader do? They go and they provide all the resources available. They try to listen for all the barriers that you are experiencing. They try to contain the people, okay? So when we have a leadership like that, the followers will be more willing to participate, more willing to do the things or participate in the programs that we have, okay? So the change of leadership styles, and I believe that all our leadership should have, as you say, like, training in leadership styles. I didn't know about that until I did my master's. And all of them should go through the training on how to be a leadership, because there are different models and there are different things you can do, and how you contain the resistance of change, you convince your people how to do things. So it is really a good thing that they go under this training. So they should promote learning, motivate staff, provide a transparent environment where patients' harm are freely shared with staff, model professional behavior, remove intimidating behavior, and provide the resources and the training necessary. Another thing we can do to increase the patient safety is integrate risk management activities, okay? So what we mean by risk management is that we have activities that will make us deal with incidents, we deal with harm before they happen. So we are proactive, not reactive, okay? We did have 2 incidents in Kuwait that we had a crisis when we had them. If you remember the bombing of the Al-Sadiq Mosque, okay, it was a chaos. I was one of the people who lost a person in that bombing. And by the time we wanted to find him, it was absolute chaos to find that person. I know that some hospitals reacted badly to that crisis that we had. Okay, so someone is doing something, I don't know. Okay, and it was really dealt with very, very badly. So another one is the COVID crisis. It could have been dealt much, much more professionally if we had a risk management plan telling us how to deal with pandemics. So if we had this risk management activities, things will be much easier to deal with crises, with disasters, and we don't have to wait until for the disaster or something to happen and then we can react for it. We should promote reporting more and more, and we talked about reporting a lot. We should implement solutions to prevent harm. So we should design systems to make it easy for the people to do the right things. We should introduce the risk management. We should do the training for the risk management. We should follow the best practices. A lot of polyclinics have done marvelous quality improvement projects, but they didn't share them with the rest of the the other primary clinics, not even in the same medical area, and I don't know why. Because if they managed to make a quality improvement project where they solved a huge problem in their clinic, others can benefit from that. So this would be good, but unfortunately we don't have this culture of sharing. Involvement of patients. Patients now, there's something called patient-centered care, where the patient is involved in his care and the treatment that he's getting. And if you want to make any improvement or if you want to introduce something in your polyclinic, the patients have been asked to give their opinion, and it has worked marvelously in other countries. Okay, and it's called patient-centered care if you want to read about it. How it's done? You collect, you give surveys and questionnaires to patients regarding anything. So if it's a safety issue, we can put a survey or questionnaire to the patient and ask them to give their feedback. We could meet with them face to face and we share stories. Storytelling and story sharing is a thing now in quality and safety, and especially with the patients, because sometimes they tell you things that you are not aware about. Have you heard about patient shadowing? That you follow a patient from the moment that he enters your facility until he ends up the service. Shadowing the patient would tell you where your process is lacking, where the gaps are existing. And it works marvelous to know where the incidents or where the gaps are in your process. The Joint Commission has developed Speak Up, okay? And this is something that they ask the patient to do. The S is for Speak Up if you have any questions or concerns, if you don't understand what the clinician is saying. Pay attention to the care that you are receiving. Educate yourself about your diagnosis and treatment. Ask a trusted family member or friend to be your advocate. Know what medications you are taking and why. Understand more about local organization and participate in all decisions around your treatment. So the patient-centered care is becoming something in safety and quality. And the last thing is to learn and share safety lessons. So even among yourselves, when you're having tea, if anyone had an incident or did an error, don't be ashamed. At the end, we're humans. It's just discuss this error. Discuss why it happened. Discuss how you can mitigate it. This discussion will enrich your knowledge about how, you can avoid it in the future. And maybe it will, encourage you to document it in the future. Okay? So you will have a culture in which safety becomes a daily focus. It will show that reporting makes a difference in the patient care. It helps increase reporting rates and help develop a team culture where we can work as a team, not as individuals. And I'm done here. If you have any questions, thank you for listening. I hope it was interesting for you. I know safety and quality is something that not everybody's interested in.
No, thank you so much, Dr. Maha, for all the information. There were a lot of definitions, but you managed to place it all in real life situations, which helps and understand. I just want to say that our head of center, what she does is every now and then she tells us everybody has to fill up an incident report. This week, please, everyone, fills up one form. And you might feel it's by force, but no, actually, if you look around you, every day you can find a situation where there's something to report. And it makes a habit. And
it depends on the culture that you are in. Sometimes forcing the incident reporting is, I've noticed this in a way that the healthcare centers had to do because they were bound by the directorate to present any incidents that are happening. So they followed that path that they kind of like, tell the people that you have to report an incident. But it worked with some people that they encouraged them to do it. And as you said, it became a habit, which it's a win situation in a way. But what we aim for is people to understand why we want the reporting. This is what we aim for. I know it's a long way with all the challenges that we have, but hopefully it's going to be there. Hopefully one day.
Yeah, definitely. I think you just overcome one barrier, which is figuring out the form. So if somebody is doing it for the first time, it's like breaking the ice. If you do it once, twice, it's going to be easier for in the future.
That's right. It's such a complicated form. I don't like it at all. I'm glad some people are simplifying it in a way of a electronic Google form thing. It's easier for access. What I ask some people to do is on their free time, just go through the form and read it. When you read the sections and you read the checklist that is there, you will have a good idea of what to report, because sometimes you come across things that in your daily clinic time, but you don't know if it's an incident or not. But if you have read the form, then it will give you an insight. So this is good.
Yeah, exactly. So I guess no more questions. So thank you again, Dr. Maha. It was great having you with us. And I think we should end the evening now.
Yeah, it was quite a long evening. Yeah. Okay, thank you for having me. And hopefully next time we will see you in person, inshallah.
Definitely it will be more practical to have the forms in front of us and filling in them up even together.
Yeah, hopefully, yeah. But, okay, good luck with the program and best wishes.
Thank you, Doctor, and good night, everyone.
Good night.